Next, Dr. Leela Mohan. So, Dr. Leela Mohan would be presenting her talk on surgical outcome of graded IOrecession with or without anteriorization and over-elevation and adduction.
Thank you, madam. So, surgical outcome of graded infero-oblique recession with or without anteriorization and over-elevation and adduction. Primary over-elevation and adduction is common in long-standing horizontal strabismus and often is due to overaction of infero-oblique. It's seen in 70% of essential esotropes and 30% of exotropia and is the commonest cause for V pattern. Primary infero-oblique overaction is bilateral though asymmetrical, secondary usually unilateral and following superoblique palsy. Positive Belchowski head tilt and face turn leads to facial asymmetry, especially in congenital superoblique palsy, which is the commonest, and infero-oblique weakening procedures like myotomy, myectomy, recession with or without anteriorization are the various weakening procedures. Grading of infero-oblique anteriorization and collapsing the V pattern has been shown with variable outcome by Akbar et al. Nasal anteriorization and extirpation are done for recurrences. So our study correlates the surgical dosage of infero-oblique recession with or without anteriorization in accordance with the grading of infero-oblique overaction as shown by over-elevation and adduction that assesses the collapse of V pattern and reduction of hypertropia. It was a prospective study of patients who presented to our department with vertical incompetence strabismus between May 22 and October 22 over a 6-month period after IEC approval. Patients with primary and secondary infero-oblique overaction were included. Those who had prior strabismus surgery and displacement of the horizontal muscles were not included. And after a detailed history taking, vision assessment and orthoptic assessment, grading of infero-oblique overaction was done from 0 to 4 as according to the amount of over-elevation plus 1 millimeter difference, 2, 3 and plus 4 more than 3 millimeter difference between the height. Orthoptic assessment was done in 9 gaze positions and with head tilt. Fundus examination for extortion was done and fundus photo whenever possible. Superoblique palsy had superoblique traction test and force reduction test as well. So grading of recession was done. Grade 1 without with less than 15 prisms did not have infero-oblique surgery. V pattern with 15 prisms and above had insertion to Fink's point. B pattern had grade 2 had infero-oblique recession to Park's point. Grade 3 anteriorization by 1 millimeter and grade 4 had insertion at the level of inferior rectus. So amount of correction of hypertrophy and collapse of V pattern were correlated and followed up for 1 month, 3 months and 6 months post-op. There were 53 eyes of 30 patients with a mean age of 11.9 years. There were 16 boys and 14 girls. Mean age was 2.5. Mean age of onset of squinting was 2.5 years. 7 were unilateral. 20 patients had bilateral infero-oblique overaction with horizontal deviation as well. Mean grade of infero-oblique overaction was 3 plus or minus 0.8. 16 patients had V pattern exotropia, 4 had V pattern ESO, 7 had superoblique palsy. Significant head tilt was noted in 43%. 34% had infero-oblique recession to Fink's point. 34% had insertion to Park's. 9% had grade 3, 1 millimeter behind the level of inferior rectus, and 23% at the level of inferior rectus. Grading of V pattern was also done between 1, 2, 3. Postoperatively, they were considered successful if pattern was less than 15 prisms, and preoperative mean pattern was 27.1. Postoperatively, it was 9.7. Significant reduction in pattern was noted in 17, that is 75%, found to be statistically significant by paired-T test. Preoperative hypertropia was graded also to 6 groups, grade 1 to 6. Postoperative success assessed with vertical deviation. If less than 3 prisms, it was considered excellent, and 4 to 7 good, and more than 8 poor. Mean vertical deviation before surgery was 13.6 and after surgery 4.8. It was statistically significant with a p-value of 0.013. So we had a higher number, almost 70% of exotropes among primary bilateral infero-oblique overaction, as is seen in Asians. Grade 1 infero-oblique overaction with less than 15 prisms got corrected by horizontal muscle surgery itself. Depending on the severity of overaction, infero-oblique recession has to be customized, and in grade 3 and 4, which is the majority we saw, some anteriorization need to be done. Though the risk of anti-elevation is there, it does not affect alignment in primary gaze, and so binocularity is not affected. And collapse of V pattern in our cases was achieved in more than 75% of the cases, and hypertropia was significantly corrected. None of the patients had a recurrence. So proper planning and grading of infraoblique overaction should be done, and change in head tilt in majority was seen. Fundus torsion also improved.
Ma'am, did you check for fundus torsion?
Yes.
How did you check, ma'am?
We took photos in older children,
Okay.
and others it was subjective, and not subjective, I mean objective by indirect ophthalmoscopy and noted
Okay.
in the case sheet. In younger children where possible, not all children, but
Okay. Because torsion would add a lot to your study. If you add the torsion, the change in the torsion which is happening after all these procedures. Because vertical correction we see, but how much of these procedures are affecting the torsional effect, that can add a lot to the study.
we did not quantitate the torsion, but was documented in every case whether possible or not.
Right, as a part of your routine workup,
Yes.
strabismus workup. Okay, so what about the cases like your severe oblique, superior oblique palsies and DVDs? How do you manage?
Most of them had a +4 and more,
Right.
and we had an anteriorization.
So do you do Elliott's and Nankins or?
Elliott and Nankins, yes.
Okay. Right. So how much is the effect that you have noted with the Elliott's and Nankins versus the Fink's recession?
Almost 20 prisms had,
Is able to
yeah.
correct.
In more than, when there is more than 20 prism, we did some displacement of the horizontal muscle as well when there is horizontal muscle
Right.
deviation,
Right.
but they were not included in this.
Right, because we are just looking. All right. Thank you, ma'am.